Everybody, I'm Michael.
Hi, Michael.
What an introduction. Oh my God. Even though I wrote it myself, I'm like, wow. Okay. All right. So it's nice to meet you all. Like you said, I work in private practice. I specialize in addiction and queer affirmative psychotherapy. And I'm going to present today about Chem-Sex in our community in particular. So, one thing I want to preface too is that for us, I think this is almost like a common, well-known topic. But the reason I think this is so important is that in treatment centers that don't have queer affirmative work, they have no idea what to do with Chem-Sex. Like, literally not a clue. I was meeting with a friend yesterday who's the clinical director of a different treatment center, great guy, straight guy, and I was talking to him about this, and he was completely confused. He's like, we don't have anyone that does this. And he told me, too, that they have a lot of queer identifying clients who come in with this problem, and they really don't know how to treat it. So, us doing this work and educating friends, colleagues, whatever, in the community, I think is so important. So generally speaking, I think of Chem-Sex as just pretty simple, as like using substances to augment, heighten, change in some way sexual arousal and practices. And what we see a lot in our community is crystal meth, is GHB, is now ketamine is apparently a thing, alcohol, you name it, the list goes on and on. And so this is kind of just like basic psycho ed, but when we use things together, the brain starts to form associations, and one thing can trigger the other. So, for example, when you have a craving to use drugs, it can trigger arousal, and vice versa. And what we find a lot with people who have developed a Chem-Sex problem, especially in early recovery, is that for the most part, when they experience arousal naturally, they experience a craving to use drugs. And that's really where they get into trouble. And there's nothing wrong with that. Sexuality is an important part of life, but if every time you are trying to access that part of yourself, you get triggered to use a drug, you're in trouble. And what we also see, too, is that this process is subject to tolerance. So there's a level of intensity that needs to be heightened over and over and over again in order to get high. And that's something that you see. I used to work at the Center for Healthy Sex, which focuses a lot on sex addiction. And that's one of the things you see a lot with that presentation, is that a sex addict, and I know sex addiction is not it's not in the DSM, it's not completely universally recognized as a condition, but sort of anecdotally we think about it. But one of their criteria is that for sex addiction is that you need to increase the intensity or the frequency of the sex that you're having to get a high from it, which is very different from quote unquote healthy sex, where you're able to enjoy sex pretty much in a similar capacity without having to increase the intensity to enjoy it. So you can have sex on Friday and you can have sex the next Friday, and both are great. But with this, there's a need to increase the intensity over time, which can really lead to riskier and riskier behaviors, which I'm sure some of us have seen in clients in different treatment centers. And it's unfortunately, someone can end up doing things that they really don't enjoy, but it just becomes part of this cocktail. And the other thing too is that this process, I think with any addiction too, it sort of eventually becomes self-defeating, because initially the substance is used to help sexual arousal in practice, but eventually it can lead to dysfunction. So it's sort of causing the problem, not helping the problem eventually. So generally speaking, I know we're all here, the rates of addiction are higher in our community, just overall. I think we can all agree about that. And Chem-Sex is highly common in the queer community as well. And I was thinking about this too, when I was putting this together, why is that the case? Why are we doing this more than other people? And I came up with a few things. And I think obviously we know that, cis gay men and crystal meth, that's been a problem for quite a while, and it continues to be a problem. But I really think that, doing this sort of thing has, for whatever reason, become a little normalized in our community. That it's okay, even if you're not an addict, to once a month do some meth and go to a sex party, or once in a while, do some G with your friends. And I actually have so many clients in my practice who don't identify as addicts, who probably aren't addicts by our definition, who will do party drugs and hook up pretty frequently, actually. And this is just anecdotal to myself, but straight friends that I have, when I talk to them about this sort of thing, it's just not very common. I don't know if it's a cultural thing or if it's just a safety thing or whatever it is, but for some reason we do it more. And again, like, G, alcohol, ketamine, cocaine, Adderall, you name it. There's a lot of different things that people use. So my general theory, I have a couple of them, but I really think that, growing up LGBTQ, we all internalize some degree of shame about sexuality just because of the culture we live in, that, no matter where you're from, generally speaking, we're given the message that being straight is better and that being queer is less in some capacity, whether that's from like your family, religion, media, anything. So I think that, all of us are left with some degree of internalized queer phobia. And again, like, I think it's a spectrum. For some people it's a lot, some people it's a little, but I think it's there. And so for me, what I think is that substances just sort of are used to, help that process when you're having sex. It's hard to access a part of yourself if you've been told for so long that it's wrong, and it's hard to celebrate it. And so I think people end up using drugs just to be able to celebrate that part of themselves when they can't do it sober. The other thing too is, I saw this a lot working at La Fuente in particular. We had so many trans and non-binary clients, is that untreated gender dysphoria. I saw a lot of clients would talk about using drugs to self-medicate that and then try to have sex or try to connect with other people. And that became a pretty common way in as well. Okay, so I kind of broke out like the recovery process into different ways. And I do want to give credit to my references. Like, I took a lot of in addition to my clinical work, but Patrick Carnes, David Fawcett, Alexandra Katahakis, like, there's some people that I really read their stuff and I used it, in putting this together, and also in my clinical work, so I just want to give them credit. But so I think there's a few things that you want to help your client do. I think first and foremost is just the psychoed process, explaining to them what they're doing. I can't tell you how many clients we had who came in who had been doing this for a decade but didn't really understand what it was. They didn't understand that this is Chem-Sex, and you're combining two things, and you're a part of this process, and do you understand that? And most people didn't. So there's that. And then I think there's like identifying healthy sexual practices, creating safety plans, which again, once you're starting to do that, you want to have a safety plan. Tackling shame, addressing underlying causes, and then eventually reintroducing sex are different phases. So in terms of levels of care, I'm assuming most people here work at facilities where the care is either residential or IOP or PHP. So I would conceptualize that during the treatment era of like that 90 days, that we're not going to do a whole lot, and most of it is just going to come down to psychoeducation and creating safety plans. And again, like, many clients find themselves in addiction treatment facilities where Chem-Sex is not understood. So I think that's why it's so important when we do referrals, when we, if we get clients in our facilities that are not appropriate, that we send them in the right place. I mean, even as a therapist too, like, sometimes you really want to work with someone, but if you do an assessment and you get to know them, you realize, like, I'm not the right person to treat this client. Just ethically, I think it's so important that we send people where they're supposed to go, because when you're new, I mean, when I went to rehab, when I was getting sober, I didn't know like the different types or the different places, or I just went to see a therapist who said, go to this place, and so I just went. And I think when you're in that space, that tends to be what happens. You don't, you're not sitting down and like researching for a month of the different facilities. You just, like, you're desperate and you go. So anyway, I think that's important too. But again, I think that yes, okay. And this part too is that I think the foundation starts in residential and IOP, but the majority of this work is going to be a more long-term process that clients are going to do with their individual therapists after treatment, which is why I think it's so important that we put them in the right place and we find them the right referrals, and that we send them to therapists who know how to do this and know how to work with it. I've had several sponsees who were working with therapists and their therapist did not understand this topic. And I'm not, throwing shade at them. Like, all therapists, we have like a basic competence of different things that we should know how to practice, but there are all kinds of levels of specialty and we don't have all of them. We all have a few. I mean, if someone called me and they were like a woman dealing with postpartum psychosis, and I would not know what to do. I would have like a general idea, but I do not specialize in that topic, and so I would want to send them somewhere else, and this is sort of the same thing. Okay, so in terms of the psychoed, and this is a part that I think a lot of clients struggle with, is that this, detaching and detangling these two things, it is a long process. I would say maybe even up to 18 months. And I think it's important to normalize that because a lot of clients I've had are hoping that this will be fixed in 2 weeks or in a month or whatever. And I mean, it's the same thing when you're getting sober too. I think a lot of us come into 12-step recovery thinking like, I'll be done in a month or I'll be done in whatever and I can go back to my life. And, it's like, it really is. I mean, the program is really like a design for living, so it's not a plan that you finish. But even with this sort of a thing, I think it's important to give them an appropriate timeline. So they know what to expect and sort of to like set expectations of what it's gonna look like. And in terms of how it happens in early recovery, I mean, a lot of people have no desire in early recovery. They're sober, and so without the substance, they're not finding themselves having any sexual interest at all. And a lot of people too will have sort of the opposite, where like they're thinking about drugs a lot, so therefore they're thinking about sex a lot, and it's like a constant reminder of this process. So again, I think the setting expectations is really imperative early on. Okay, so this is a big kind of like a point that people kind of wrestle with. So a lot of people will suggest temporary abstinence in early recovery of just sort of taking a break from everything, which I personally agree with. Under conditions. I don't think that, and I think the most important thing too is that we don't want to shame people. We don't want to say sex is bad or sex is dirty or don't do that or you're doing the wrong thing. But we want to help give them time to break this association that they've made. And so I really do think that having some sort of timeline of a break is really important. And it can be flexible. It could be, it could be 3 months, it could be 6 months, it could be 9 months, it could be something or other. But I think the most important thing though is that when you're on that break, that you're working on yourself. Because I've seen a lot of people fail because they are abstinent from sex, but they're not actually working on that part of themselves in therapy. And so it's just sort of like a timeline, and then they hit the end of it, and they don't feel better, and they get frustrated, and they go out. So anyway, some people really don't like that idea, and they want to just start to have fun right away. And I would just caution them against it because I think it's dangerous. Even this too. I mean, people talk about like dating and flirting and well, and obviously it's like perfectly appropriate to experience attraction and desire and so on and so forth. But there is a difference between noticing someone and kind of having an interest from afar and like actively pursuing them. And I think you can really kind of differentiate the two and suggest like you can continue to notice your attractions and celebrate them in your own way, but not to pursue them for a couple of months while you're getting this under control. And this too, this one's a little tough too, but some people will avoid masturbation also, which I personally don't think is healthy, but some people do it. And I kind of leave it up to clients themselves. If that's something they want to do and they think it's important to their recovery, I'm not going to stop them. So it's something to consider, and I would at least make sure you have that conversation with them so that they understand that it's okay to talk about it, and that it's a factor to consider as well. Okay, so this is, I think, also something I started doing this at La Fuente, which is taking an extensive sexual history, which I personally have never had a therapist do this with me, and I really wish that they had. I mean, they'll talk about sex and sexuality, of course, too, but really getting into the weeds with someone about how did your sense of sexuality develop. And this is something, if you work with someone who's like a certified sex therapist or like a CSAT or an ASECT, they do this sort of thing, but I think your everyday average therapist probably does not. And I personally, don't always use this as well too, but I think it's important. But so asking just sort of simple questions about like what was the atmosphere, about sex growing up, what is the earliest memory you have that was sexual, how did you learn about sex, what did your parents teach you or not teach you, masturbation, porn, first crushes, sexual fantasies, how do you identify your sexuality, and so on and so forth. And I think this is also important too because as queer people, we're often not invited to discuss our sexuality. I don't know about you guys, but like when I was growing up, straight guys, all they would do was talk about girls and tits and the porn and whatever. And like my brother had like Shakira on the wall, and like it was a whole thing. And so, but like, and I think that's great. Don't get me wrong, but like they're encouraged to celebrate it and like, yeah, this is awesome, and whatever. And I think we should have the same experience too. So I think that we can kind of not only have an affirmative environment for our clients about sex, but we can really celebrate it and encourage them to have fun with it and know that it's a great part of them. And again too, like belief systems about sex and intimacy and body image, and I mean the list goes on. And I think also too, doing this kind of assessment can be really diagnostic because you can get a sense of how comfortable are your clients even discussing these things. If you sit down with someone and they're just kind of open and relaxed, that gives you a sense of how comfortable they are with this part of themselves. And if they're really, really uncomfortable, not that we want that, but it will give you a sense of, okay, this is probably how far this person is in terms of celebrating themselves and being comfortable with sexuality. So there's that. Okay, so this is also something that's like very, very, very subjective in terms of identifying healthy sexual practices. And I looked up a lot, and I even, the references I made to of these people that are sort of pioneers in the field about what is healthy sex versus what is unhealthy sex. And it is such a subjective thing, and I really didn't want to distill it down to something that was just my personal opinion. So I kind of left it really general and vague on purpose. But a couple of things that I think we can maybe all agree on that are unhealthy is if sex is driven by shame, if it's being used to numb or escape your feelings. And I think also a really important thing too, and we could probably all relate to this too, but if afterwards you have some sort of unpleasant emotional experience, I think that's a really good indicator too that what I've done is not healthy to myself. Even if it was perfectly consensual and fine, if you're left feeling kind of like icky about it, I think that says a lot too. And then in terms of healthy sex too, I think it's like it allows us to enjoy our feelings. It's authentic to who we are. It can include romance too. And I also put a really big important note here that I think it's important that we don't define, healthy sex as like a romance novel where it's like, two people that love each other and have gone on 15 dates and get a hotel in Santa Barbara and whatever, and it's like this perfectly, like that's not what we're saying either. I think that like brief sexual encounters can be just as fun and celebratory and authentic to you as some sort of long, drawn out, married couple who's having sex or whatever. So that's something I really like to preface with people, that we're not trying to slut shame them or suggest that it should be more or less or whatever. It's just about finding an experience that's authentic and healthy to you, whatever that looks like. Okay, and so tackling shame I think is one of the biggest things. I think we can all agree, like whether you're approaching a client from any modality, whether it's like CBT, DBT, EMDR, intergenerational trauma, you name it, that there's always some sort of sense of shame that can drive mental health to be, affected in a negative way. And I think this is no exception too. And I think we've seen a lot that shame can drive the addictive process. And I think it's true for Chem-Sex as well too. And in my opinion, I think the biggest way to tackle shame is through the group, is through like community and so on, groups and so on and so forth, like AA, CMA, NA, SLA, SCA. I think, Gen Z, for all of their issues, I think they're so good at this. Like they're very comfortable outing themselves about whatever issue they have. Like as a therapist, when I work with people who are 35 and up, for them to label themselves as like, oh, I have depression, or oh, I have bipolar, or oh, I have an addiction, it's like they're whispering and shrinking, and it's such a shame-based thing. But I don't know about you guys, when I work with Gen Z, they're just like, oh yeah, I had a psychotic break yesterday, or oh, no big deal, I did this, or oh, it's like no problem. And it's like, this is so great. It's such like they don't throw like, there's a problem obviously that has to be addressed, but they don't throw this like giant level of shame on top of it, which is so freeing and so healthy. And it gives me hope that like, wow, we are getting better in terms of how we deal with mental health. Even in terms of, I think we can all agree too, but when we were coming out queer was a lot more of a loaded process. And for them, it's like, not no big deal, but it's much different. It's much different. I have a younger cousin who has, she's autistic and she's also non-binary and goes by she, they, but so open, just announced at the dinner table one day, was like, give me my pride flag, like just so free. It was like, great. So anyway, but I think that the way that we deal with shame is really kind of like outing ourselves and being public with what we're going through. And it doesn't have to be like on social media or getting like a billboard or, whatever, like having a huge deal. But when we go to meetings, when we do group therapy on a group level, I think that we really see that we're able to tackle our shame because people either have the same problem or they see us and we're able to, it's no longer a secret that we're hiding about ourselves. So, and I've seen that a lot in terms of Chem-Sex too, of when I was doing groups at La Fuente, other clients were talking about it, and there was a lot of like, oh wow, you did this also, and so on and so forth, and even at at 12-step meetings. And I know personally, being in recovery, when I hear someone share something that's like I'm ashamed about of myself, it is like monumental, because it just feels like, oh, I'm not the only one doing this or going through this or whatever. I also think too that, again, like having educated clinicians who know about this issue is so important, even if it's not your personal issue and this isn't your personal journey, but to be able to invite it into the space, I think really, really takes away shame. And last thing I'll say too is that I also think it's our job to do that. Like, it's our job to let clients know that you can talk about Chem-Sex and that you can talk about sexuality, rather than saying, well, I'll wait for them to do it. Same thing, I think, when it comes to like talking about race and privilege and so on and so forth. Like, I think it's a therapist's job to invite that conversation, rather than saying, I'll wait for you to talk about it if you're comfortable. Just to sort of name your stance and like, this is a space where I invite this in. So I think this is sort of the same thing. Okay, so, and this is kind of like in detail too, but one thing I like to talk to clients about who have come in is like, I use this term sexual template, which is basically like physical, emotional, intellectual characteristics that we find attractive, which like height, build, I mean, you name it. I think that a lot of people haven't sort of considered themselves in these terms before, of like, what is my arousal template and how detailed is it? How rigid is it? How flexible is it? And neither are good or bad. I mean, if yours is very narrow and very simple, like no problem, versus if you have like a plethora of different things that are interesting to you, that's great too. But I think it's an interesting way to help people understand that we all have some sort of template that's become fixed at some point in our life, and that we can, the more we understand it, I think the more you can celebrate it and explore it in whatever way you want to. So yeah, because there's that point. And then again, like obviously the goal in terms of recovery is to remove shame and also to create a sexual practice that no longer involves drugs. And that's something that I'm really, really strict about when I work with clients. That is, the goal here is not to rework things and then you can also continue to play around with, Chem-Sex later on in your life. Like, that's not what I'm trying to help you do. In my mind, like, this is a problem that we need to stop. And this is an addiction that we need to stop. And we need to find a way to keep you healthy going forward. So I like to label that too, because a lot of people will be resistant. They're going to want to continue to do this behavior. I mean, I think we can all relate, those in recovery too. When you start going to meetings and you start going to rehab or whatever, there's a big part of you that still wants to drink and use because it's been working for so long or for whatever reason. And so there is that kind of like, I do want help, but I'm also defending the addiction too. So you just want to be mindful of that as well. And again, too, I would say that, queer folks, like, we don't develop sexuality in a way that's very organic, and there's always some degree of shaming to it, no matter where you come from. So I think, inviting clients to start to re-examine this part of themselves in a very affirming, organic way, I think can be really healing, and it may be the first time they've ever been sort of invited to do that. Yeah, okay. And then there's this, masturbation. So again, this can be different for each person. Some people want to take a break, some people don't. But I think maybe this goes without saying, but before you go back to exploring sex, I think that re-engaging in masturbation is the first step you should do. And even in this, like, I know it sounds like probably a simple thing that we've all been doing since we're 11 or 12 or whatever, but if you're in recovery from Chem-Sex, it can be a very tricky topic to navigate because it can trigger cravings. And it's something important too, like with my clients, when I talk about reintroducing it, I really try to normalize that you will likely experience cravings, and that's fine. And you're not doing anything wrong. It's just part of the process. And I really try to like keep the therapy very kind of close and simple while they're doing this, so not to overwhelm them with things that they, that they're going through and so on. And one of the things I've seen that really drives people to go back out is sexual performance or sexual dysfunction. If they can't orgasm, if they can't get an erection, if they can't maintain an erection, things like that. So I really try to normalize clients too, that is part of the process, and that they will be able to regain sexual functioning, but it may be a little troublesome in the beginning, and to not get discouraged. Because I've seen a lot of clients too, like they try it out, it doesn't work out, and they're like, forget it, I'm gonna go use. because it's just easier. Another thing too that I think is, interesting too is just they call this like I think they call it mindful masturbation, but it's kind of more of like masturbating but focusing on body sensations rather than because I think a lot of people are pretty accustomed to using porn or whatever it is, which is fine. But I think it's like another way you can kind of reintroduce sexuality to people of like, why don't you try doing this a different way and see if you like it, and maybe it'll be fun. I don't know. Yeah, also porn too, and like I'm not against porn, but I do think it can trigger this sort of reliance on external stimuli for arousal. And also, one thing to really caution your clients about is that they do not stumble across using porn or porn that is triggering, because that is out there on the internet and a lot of clients have been using it. And that if they're going to watch something or look at something, to really be careful that they don't accidentally, click on something that is going to trigger them too much.
Can that become an addiction as well?
Excuse me?
Can the porn become an addiction as well?
Yeah, I mean, I think, it's sort of the same thing with sex addiction, where I think porn can be used compulsively. Yeah. When people put the word addiction behind it, it's like, there's some people that would say yes or no, just depending on how you, like, what paradigm of addiction that you use. But I agree. I mean, I think people can use porn compulsively, and that's obviously not what we're trying to encourage in recovery. Sure. That's a good question, though. Okay, so exploring sex again. This is like kind of where the rubber meets the road. So obviously you want to make sure that your client feels secure, feels resourced, enough to start doing this. I would never want to encourage someone to go through this process when they're in kind of like a shaky state, or that they're not quite oriented or anything like that. So I would just really kind of preface that too. And if you have a client that wants to start exploring this, but say that they've just recently unearthed some new trauma in therapy, that maybe we wait a couple months until you kind of sort this out and get a little bit stabilized again. And so again, like normalizing that there may be poor experiences, they may have cravings, and then that's fine, and embracing patience, which I know is hard, but it's something we want to do. Also too, avoiding risky scenarios. I mean, one of the things that we used to always say when I worked at La Fuente was to not let clients get on apps, because and some people may disagree, but I think, if you're in recovery from Chem-Sex, I would just say no apps for a long time, just for a really long time. All of them, like Grindr, Scruff, BBRT, Sniffies. I mean, even Tinder, Hinge. I don't even know if gay people go on Bumble, whatever. But I think it can stimulate that same excitement that they used to have. And I'm sorry, but there are drugs all over those apps, all over them, even if you're not looking for them. I mean, like, I have friends who are normies that'll be like, what is this cloud thing, and what is this capital T, and like, whatever. So
the question in your profile to answer says like drug use.
Yes. Yeah.
Frequently, all the time, socially. Yeah, it's great.
Yeah, agreed. So, and we've seen so many people lose their recovery to the apps. So I just think it's not worth it. And I tell sponsees to clients too, like, you may have to do this the old-fashioned way. See a guy at the gym, go talk to him. See someone in the coffee house, go talk to them. Like, this did used to happen before apps, and you may just have to do that.
Scary.
Let's see. And another thing too is I am challenging distortions. A lot of clients will come in, when clients come into therapy in general and they have unhealthy belief systems, and if from like a CBT perspective you want to start to challenge them of like, how is this true, and that sort of a thing. But a lot of clients will either normalize Chem-Sex or romanticize them. I can't tell you how many people tell me like, oh, but it's the best thing ever, and so on and so forth. And I'm like, help me understand. And I make them list all the consequences and all the infections and all the whatever that came with it. So like, figure this out for me. How is this the best experience you've ever had? And the truth is, like any addiction or any high, the most exciting part about it is chasing it. That's the same thing with any substance that you do. So you enjoy the chase and that there's a thrill there, no, okay, fine. But once you do it, you're plunging into like the pit of hell. So explain to me how this is fun for you. And I would just really kind of push back on that pretty hard. I'm sorry, but unless you can convince me that this is healthy and fun, which you haven't, I'm not going to co-sign it. And no one ever has. No one has ever convinced me. So that's something that's important to me too. And also really too that I really reinforce the idea too that Chem-Sex is self-harm and it's deadly. like that this is not a minor problem, it's not like a kind of sort of gray area, that this is a serious problem that needs to be worked on. Because people will minimize. I mean, I did, addicts minimize. We do. Like, oh, it wasn't so bad. I wasn't really at risk. Well, and things like that. I think have to be really, really, really challenged. Because I think, therapists that don't work with addiction, I think it's so easy for them to get like duped into believing our lies, that, I've had so many clients come from other therapists who they're doing all kinds of crazy stuff and their therapist was like, well, I guess it's okay in moderation. I'm like, we have a way of manipulating and convincing people. And I think we have to be really mindful of that too. And sometimes I do too. Sometimes I catch myself, I'm like, why did I go along with this? So anyway, I think it's important to be aware of. Oh yes, and this is one thing I really, really like. Patrick Carnes is one of like the sex addiction, psychologists or whatever. He uses this circle plan to identify healthy sex and boundaries. And his is from a paradigm of sex addiction, but it's basically that you list your bottom line behaviors, your inner circle, which is like things I will not do. And then you have a middle circle, which is kind of like things that are on the edge and kind of in the gray area, maybe risky. And then you have the outer circle, which is like healthy stuff. Like this is what I want to be doing. And just to be very clear with yourself about what is good for me, what is bad for me, and what is me kind of putting myself at risk. And I think that's really useful. And groups I used to run, we would do that, and we would kind of compare notes. And it was funny because some clients, like their healthy behaviors were so unhealthy. I mean, they were so destructive. And you're like, well, okay, I'm glad we did this so that we can rework this. And also having them compare to one another was really useful too. Let's see. Yeah, and again, like keeping yourself accountable. I mean, I think this comes with recovery in general, but when you're new, and even when you're not, I mean, when you're doing something that's kind of risky or challenging, just to keep yourself accountable. Keep your sponsor involved, keep your support system involved, keep your therapist involved. I mean, with whatever, and I think this is no exception. When we do things in isolation or with some level of secrecy, I think we set ourselves up for relapse or just, unhappiness. So again, I think this is no exception. And then, okay, another thing too is that, with all addiction, we obviously want to address any underlying cause that could be a part of it too. Sometimes there is like more than meets the eye. So again, like we want to assess for any mental health condition that could be leading them to self-medicate, whether it's like a dysthymia or a bipolar disorder, an anxiety, trauma or PTSD, anything underlying all this behavior and addiction that's there, because if you don't, it's going to start to push the addiction back. If they're dysregulated by another condition that's not being addressed, it's going to be a problem at a certain point. So definitely ruling those out, I think, is very important. And then someone brought this up to me recently, and I was kind of hesitant to put it in, but I did, because I don't know, I'm a little bit on the fence of how I feel about calling things sex addiction. And again, I know that there are a lot of people in the field that believe in it and a lot of people that don't, so I kind of stand in the middle. But the reason I decided to put it in is that a lot of clients I've had have told me I'm a sex addict, or I'm a sex addict, or I'm a sex addict because of all the stuff they were doing when they were the compulsivity and so on and so forth. But I always tell people that is a possibility. You may have a sex addiction that was exacerbated by Chem-Sex. That is possible. But we won't know until you get sober. Like, there's no way to diagnose this. I mean, there's no way to really diagnose anything until you stop using. So let's get you sober first, and then we can sort of see what else is there. But I also think what can be useful is getting a very clear timeline of when the compulsivity began. Because if there was no compulsivity prior to using, then I don't really see any reason to consider it sex addiction. I mean, we can keep it as like a rule out. But it is true. I mean, I have seen some people where before they ever started using, there was a lot of compulsive behavior, like a lot of compulsive behavior. And so then they may need additional treatment to focus on that part of the mental health picture as well. So I think it's important to note. And then I think this is the last one. So exploring transference and countertransference. So obviously this topic is very charged, and it can bring up reactions in therapists and in clients, naturally. So I think it's important to be mindful of those. I think obviously erotic transference is a big one that clients that are this is actually really important. Clients that are so used to sexualizing everything, will do it to you too. That's just becomes so habitual. So just being mindful of that. And one thing I would do well, I do this with clients in general, but when I would do assessments or do this kind of work, it's just sort of check in about, what's it like for you to talk about this? What's it like for you to talk about this with me? What's it like for you to talk about this with someone who identifies as gay? And just kind of bring that into the room and see how it goes. I mean, I think that's important with anything too. If I'm working with a person of color, it's the same thing of what's it like to talk about this with me? I identify as white. What's it like for you to talk about this with me as a white person? Just sort of bringing that in of like, I want to understand our dynamic too as part of the work we're doing together. And then I do acknowledge, all the different things. And then also too, being aware of like any kind of your own sexual beliefs. If you are maybe more limited or more conservative, that you're not accidentally kind of like shaming people for what they're doing. And trust me, I'll be honest, like I'm a pretty open-minded liberal person, but sometimes I hear things and I'm like, what? Like there's a part of you that's like, I don't know about that, And so just being aware of that too, that we are human and we're going to have reactions to things, and it's okay. And maybe I do catch myself having a judgment about someone's behavior, and that if catching it is good. It's bad when I don't catch it. And I can talk about it with a colleague, or I can get supervision or consultation or whatever it is. But just to be aware of those things, that we all do have judgments and biases, and that's okay too. We just don't want to get lost in them. And then I think also too, just examining also, again, like their reaction to any of this type of work and making it an ongoing dialogue too, that they may be 6 months into it and start to get frustrated with you. I've had a lot of clients who are frustrated with recovery, who then get frustrated at me, as though I'm gatekeeping sex from them, of like, you won't let me do this, or you whatever. So I just kind of make that, rather than being combative with them, just make it part of the process of like, what's it like for me to hold a boundary with you? What's it like to be in a space with me where I don't allow you to do something destructive? And just sort of make it like a very interpersonal process sort of thing. And I think that's it.
This is a time, if anybody has any questions, please raise your hand, and I'm going to come right over. Anybody?
I'm like, why are you coming over? What do you got? With the love addiction thing, right? I've done a lot of reading and with different therapists on attachment, attachment wounding, like the love addiction idea. Is there something for this? What's the theory?
But behind love addiction?
Yeah, love addiction, it's attachment wounding, basically, like that's, so is this different? The sexual, is there a...
Do you mean love addiction with Chem-Sex?
No, I was just using that as an example.
Okay, yeah, so I would say this is pretty specific to people that are using drugs with whatever else is going on with them,
okay.
whatever other behavior they're doing, excuse me. Yeah.
So anyone, it's not sort of a trauma response to something.
I would say that it could be, but there's layers you have to go through to get there. Okay. So you have to, obviously stop the behavior, establish safety, give them the education, help them reintroduce the behavior in a healthy way, and then any kind of therapy, as you kind of go through it, you start to be aware of is anything triggering this? Is any underlying condition? And obviously there's going to be any trauma component to anyone. I mean, that's just going to be part of the picture anyway. But I think I think what you're describing is a little different. Yeah.
So it's important, it's just not important in the beginning. It's not a consideration in the beginning. It'll come out in the wash.
I think if there is some sort of, I think attachment wounding will probably be there with anyone who's struggling with addiction. It's very likely. I mean, maybe they don't, but I would say 90% probably will. Mm-hmm. So, and that will come up in the therapy too, if it works. Any attachment wound will become very apparent within the dynamic too over time as they get attached to you.
Right.
So that will be a really a good litmus test to see what they're struggling with in that capacity.
And then the last thing, do you know Alan Roberge on YouTube? He does an attachment wounding. He's a therapist.
I don't.
It's very good. It's a very good resource for education. Is there a resource online, something easily accessed, free?
About Chem-Sex?
For education, Chem-Sex, yeah.
Yeah, I could send you, there's some books you could, there's some authors and therapists who've written about it that
Okay.
that I could send to you.
Yeah, I'd love that.
I would say like that. What I try to do is kind of marry like because a lot of the sex addiction literature is for straight people in general. And there is some Chem-Sex literature for gay people, but I kind of try to bring them both together. But I can definitely send you references that I have. Yeah, absolutely.
There's a documentary too.
I think she had one.
Yes, I've seen it. Yes.
What's it called? Chem-Sex.
Yeah. Quick and
So
easy.
that is what we call this, Chem-Sex? Like
Yes.
that's- Okay.
Yes.
Thank you so much. This was this was so informative. So my question as a heterosexual person is, I definitely can identify with Chem-Sex. I've been sober now for double-digit years. What would you say the percentages, and when did the word Chem-Sex become part of, an identifiable type of part of what addiction was? Because I definitely know half the people I used with were Chem-Sex.
Yeah. Yeah.
And as well as, the LGBTQ world. So I'm very curious about that.
Yeah, that's a good question. I mean, I would say that, well, I don't know this for certain, but my guess is the issue with crystal meth in the gay male community probably really exacerbated this issue just in the culture, and then clinically it became an issue because more of those clients were coming into treatment. I don't know if it was, it might have been David Fawcett, or it might have been one of these authors who wrote some of these books that coined the term. I don't know who would get credit for it exactly.
How many years ago would you say? So I've been sober now for 16 years, and Chem-Sex was not used a lot back then.
Maybe 15 or so.
Oh,
Yeah. Yeah.
Okay. All right. Interesting.
Hi, thank
Hi.
you for today. What are your thoughts on limiting or restricting social media, especially when you open up your social media and on your feed and the algorithms are just feeding you a feed of half-naked
picture.
men?
That's a good picture.
How dangerous do you think that is for somebody that's recovering from Chem-Sex? Do you think that there should be limitations and restrictions around that? How far deep do you go in
Yeah.
the restrictions?
That's a good question. I mean, I think that something like that, I personally might make it specific to the client. So what is it like for you to open up your phone and see a bunch of half-naked guys on Instagram and just sort of go into it with them? Is it triggering? Is it arousing in a more innocuous way? And just see what they say. Because I hear what you're saying too. I mean, there's some things that are obviously blatantly risky and dangerous, and there is a lot in the gray area. So I would talk to them about it too. And I think that's where a circle plan may be useful, because you get specific for each client of what's risky for them. Because what you're describing may be totally fine for 10 people, and then for one person it might be a big problem. But that's a good question.
We got a couple here.
Hi, thanks again. How hard is it to come back if you have a long time sober? I know somebody that had 12 years and he's out, and it's just seemingly he's not making it back right now.
How long would it take for someone to?
Yeah, I mean, it's just my question is how challenging is it to come back once you have had sober time and then you're now in the grips of this disease?
Well, I would say, maybe depends on the person, but
Okay.
generally speaking, this is not easy. I
Yeah.
mean, this is hard. I mean, I think obviously getting sober in general is really, really difficult. And this type of presentation is really tough. But it's doable.
Okay.
It is doable. I hope he comes back.
Hi, I'm working with somebody in substance abuse right now that suffers a lot from this, Chem-Sex. So I'm wondering what kind of resources I can point them to, for therapy after or help.
Are you working with them in a facility?
Yeah, I'm at a residential nonprofit that I'm working with them on substance, but this is something he spoke about that always brings him back.
Oh, okay.
It's been
Okay.
multiple times.
Okay, so I would suggest, and I can send them to you, but I would suggest doing a history with him, like a sexual history with him, talking about safety plans of what's he going to do after, and establishing with him what's really dangerous, and then getting clear about what's the gray area for him in particular. I think could be really useful. And some of the basic psychoeducation, and then when he leaves, setting him up with people, with clinicians who know how to treat this.
That's what I wanted.
Yes.
If, like, possible, if you have references.
Yeah,
or
oh, for
something.
sure. Absolutely.
Thank you.
Yeah, no problem.
I was just, oh, you can go somewhere else? Okay. I was just curious if you know statistics on like the percentage of gay men that are doing this on the regular.
In the community, I don't know how if it'd be possible to get statistics like that. I guess, I don't know. I'm not sure. But I don't know. It's funny when people talk about, I only took one statistics class in college, but it taught me how much statistics are crap. Because like, and
You can
so
make numbers say anything.
you can make numbers say anything. That's a great way of putting it. And when they do statistics about the efficacy of AA, I'm like, how?
Right.
How? That makes no sense to me. But even when it comes to drug use, because I'm like, how many people are going to disclose this honestly? Even if you do choose, say you do choose a sample size of people who are very willing to be like, yeah, I'm a meth addict, which I don't think is likely. But even if you do, like, how do you know they're telling the truth? So, yeah.
Right. Yeah.
Anyway, that's where my
It
mind goes.
just, like, I live in San Diego, and it feels like when you're on the apps, it does feel like it's everyone.
Yeah.
I know it's not, but that's what it feels like.
Yeah.
Okay, I'll come back to you.
One, can we get the PowerPoint?
Sure. Yeah.
So so someone who comes into residential and they're coming in, going through the detox process, how much of this is a secondary issue to deal with? And do people come in and they actually recognize they have it as part of the journey, helping them to understand what's going on?
I think it's the latter that you just said. Some people do come in knowing about this already and presenting it, but I think a lot of them don't. So I do think it's our job to, like when you're in treatment, you have different groups about different concepts that sort of to jog people's thinking of, oh, maybe I have intergenerational trauma, or maybe I have a depression, or you kind of throw a lot of different ideas at them and see what kind of jogs they're thinking. And obviously their primary therapist does an assessment to go through all these things to rule things out. So I think it is our job to suggest it for sure and to help them identify it if it is there. But even if they already know it, then you can get really into the treatment for it. Yeah. Does that answer?
Yeah.
Okay. Oh, really? Yes. 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 Oh, nice.
I was like, I know this, but let me look at my notes.
I had a question. You were talking about at the beginning kind of like being super transparent of like this is a long process, like 18 months, be patient with yourself, be gracious with yourself. Can you talk a little bit about how you kind of package the idea of the fact that it may like never be as intense, or just that it like will be different after that point, and being like up forth or upfront about that?
Yes, I'm super upfront about it. That's a great question. So, I always phrase it first of all that like my motivation is to stop this behavior so that this won't happen anymore in the future, and that you can enjoy sexuality in whatever way you enjoy, but that it will not include drugs. And right there, a lot of people will kind of push back on you of like, well, I still want to do this and I still want to do that. So, and for me personally as a therapist, like I'll spend a little bit of time with people in that area, but I don't do a lot of harm reduction work, and I definitely don't with Chem-Sex. So if their goal is to continue to use drugs and sex in any capacity, if they're a Chem-Sex addict, then I won't work with them. Because that, for me, that just feels like I'm not trying to help you do a self-harming behavior less. Do you know what I mean? So, yeah, no. So I'm not doing that. I'm not doing that. But to your point too. So I do make it very clear about the type of sex that you were having is not going to happen anymore. But you're going to get to explore a lot more and a lot more enjoyable, in my opinion. And then I kind of see where they go with that. Like some people will just kind of understand that, okay, I'm not going to do this anymore and I'm going to let it go. People that won't, then I'll kind of go into why. What are you giving up? What is so important about this? What do you need? What were you getting from that you can't? Because there's some validity there. A lot of people who want to explore their kinks have only been able to when they're high. So that's valid, but let's just find a way to do that sober. But if it just comes down to I just really want to enjoy the being so fucked up and having sex, then that will kind of come into like almost like a grieving process of that won't happen anymore. So how do you feel about that? and they may be sad, and that's fine. That's fine too, as long as they're mostly on board with the plan. Does that make sense?
Yes.
That just stemmed another idea, another thing I'd like to hear you discuss is, say a patient doesn't have intention to engage in Chem-Sex in moderation. They're like, I am dedicated to my recovery, but then they do have a lapse. How do you navigate that? Because I'm just thinking with the shame piece,
Yeah.
I could see someone like not wanting to talk about it. I'm not going to bring this up because
Yeah.
then, or I'm just going to ghost you on our next session. You know, things like that. But like, how do you navigate that so they, you know, if they experience that lapse, they still have that support for continued recovery?
That's a great question, and I think dealing with addiction in a treatment center, you know, you have the appropriate level of care, you have all these resources, so it's one thing. Dealing with it in a private practice is you really have to be careful, just in terms of like a liability perspective and an ethics perspective. You can't have someone just doing drugs and coming to therapy every 4 weeks.
Yeah.
Like that's not a thing. So you have to be, for me, it's very, very case by case. And I'm really strict too about like, you know, therapy is every week, and if you're not going to come, you need to reschedule. And you know, if we've been working together for 3 years and you're in a kind of a maintenance phase, fine, we can be a little bit more lax about it. But if you're newly sober, like there's a strict plan that you need to stick to. And if someone won't stick to it, then I won't work with them. Just honestly, because I don't think it's going to work, and I don't want to be a part of it.
Yeah.
And it's the liability, frankly. But okay, so relapse I think really is a case by case basis. If they are really committed to the work and they have a relapse, but they want to work on it and use it to understand what was going on, then no problem. And we can go into it, and we want to address it, to your point, in a way that's not shaming and useful. If it continues to happen, then I have to refer them to a higher level of care. But there are people who have won and learn from it, and it's fine. If they have some sort of relapse, but there's a lot of resistance to looking at it, and then I might be really weary about continuing. Yeah.
Thank you.
To add to that, what if you are working with someone? I've worked in the field for 22 years, and he's actually a sponsee of mine. They would love me for some reason to sponsor them, but like, he'll get a lot of years sober. Like, we're not talking about like 1 or 2 years. He'll get like 6 years, 5 years, and then do this cycle. And we've done all of, you know what I mean? We've been doing this dance for a really long time. How can you speak to that as to maybe some interventions or what you think might be going on?
Well, so in his opinion, what's taking him out?
He doesn't really have an answer. He's like, it's I don't know. And I'm like, I feel like you do know and you just don't want to tell me. Like, I think there's something there that he's even ashamed, even though we're close, to tell me.
I'm with you.
I think maybe he was raped or something, you know what I mean? Like, maybe he liked it. I don't know, because we've done some deep work. I mean, I don't use my clinical with my sponsees, but I think, am I right? My intuition is telling me.
So where my mind goes, and you know, I'm very psychodynamic, so believing in like unconscious process and so on and so forth. But
too.
I think that when you work with clients, you can tell that there are some parts of themselves that are out of awareness.
Yes.
I mean, same with myself. Like sometimes I'm like, I don't know where this came from.
Yes.
And we reenact things and we repeat traumas and so on and so forth. But then there are also people who are withholding of information. And I don't judge that because I've done it so much in my own therapy, out of my own shame and my own whatever it was. But when I work with someone and they give me the answer of I don't know, I'm always really suspicious.
Same.
I'm always, because people that don't know but are curious will try.
Yeah.
They'll kind of go like, well, maybe it's this or maybe it's that.
He's done that, but it's like the last couple times, it's like, but now it's getting like shorter stints, right? Instead of the 5, 6, it's a couple, and I'm like, what the fuck are you really doing?
Yeah. I mean,
sorry, my pets, like.
When clients do that with me, of like they kind of stonewall me with like I don't know, I just kind of will ask me, well, what do you know?
Yeah.
Well, what are you aware of? And try to go with that. And if they really won't give me anything, then I'll just kind of say something like, you know, I am not understanding you.
Yeah.
And I want to,
Yeah.
but I'm not understanding.
Okay.
And just try to like speak to what they're doing.
Okay.
But you know what? Also, and I'll shut up after this. But therapists, like, we're not magicians. It's not our job to, you know, put someone under a spell and fix everything. So they have to be willing to some degree. Yeah.
Awesome. Such great questions. That's all the time, guys.
Thank you. Thank you.
Thank you, Michael.